It's a pleasure and honor to introduce Dr. Noemi, consultant hematologist at Oxford University Hospitals, working on patients, both clinical and academic, and interested in inherited anemias. Professor Noemi is going to give us a talk today about genome therapies in hemoglobinopathies. Please take your seats, please, Professor Roy.
Thank you very much. Thank you, Dr. Azza, and thank you to Dr. Amal Bashlawi as well. I'll start again. So thank you, Dr. Azza, and thank you, Dr. Amal Bashlawi, for this very kind invitation. It's a real pleasure to be here again and to be able to speak to you all about genome therapies and hemoglobinopathies. So today I'm going to talk about some of the very basics about DNA and chromatin, which is important to really be able to understand all of these genome therapies. And then I'm going to spend most of my time talking about gene therapies, and at the end I'm going to explain a bit about genome editing. So I'm going to talk about the details about the technology and some obstacles, and then some applications for both thalassemia and sickle cell disease. So if I start with the building blocks of DNA and chromatin. So we think of DNA as a double helix with the bases that are paired, but of course that's not the nature of DNA in the cell, and DNA exists packaged into chromatin. So if we look into more detail about this chromatin, this is made up of histones, and DNA is wound round twice around each nucleosome, and then it goes to the next nucleosome. And this is really important because this is a big part of how DNA is regulated, how genes are regulated. Because obviously if DNA is tightly packaged around the nucleosomes, then it's not accessible to transcription factors, and transcription factors really can only access open DNA. So this is what we would call heterochromatin, which is tightly packaged DNA, which is associated with lack of transcription, and this is euchromatin, where the DNA is unfolded, accessible to transcription factors, and is transcribed. And when you look inside a cell, you can quickly see where the euchromatin and the heterochromatin is. So these black dots are the heterochromatin, where the DNA is tightly packaged, and then the rest in the white is the euchromatin. So let's look at gene therapy and the technology. So the whole concept of gene therapy is that you take some hematopoietic stem cells from the patient, and then ex vivo you introduce a lentiviral vector, which is going to introduce the new gene. Meanwhile, the patient undergoes myeloablation and then receives the modified or gene therapy treated stem cells and undergoes an autologous transplant. So I've done this little cartoon to really illustrate how this works. So this is the cell, this is the lentivirus, and this is the gene that we're adding. Now let's imagine this is beta globin, and this is the defective beta globin, and this is a beta globin that has a normal structure and function. But the problem with gene therapy is that you can't choose where the new gene is going to integrate into the genome. So it integrates somewhere randomly, and then it should hopefully start to produce lots of the new fixed gene. But the fact that it integrates randomly is part of one of the major obstacles of gene therapy. And this is because with the random integration, you can end up with not enough gene production, which is due to silencing, or too much, which causes leukemogenesis. So if we go back to this idea of euchromatin and heterochromatin, I've done on this cartoon, this is the heterochromatin, which is the nucleosomes that are tightly packed. If your gene integrates in an area that has a lot of heterochromatin, then that heterochromatin can spread and can cover up the gene, and that gene will not be expressed. On the other hand, imagine a situation where you have an oncogene that's being protected from being expressed by heterochromatin, and your gene integrates nearby. Now these genes, when they're integrated, they come with their own enhancers, and this is going to drive its own production. But the problem is that when it drives transcription, it's going to spread the epigenetic changes and undo the heterochromatin and turn this region into euchromatin. So the problem is that you're going to start to produce lots of this oncogene. And therefore, there's a risk of leukemogenesis with gene therapy. And in fact, the very first gene therapy trials, which were done on SCID patients, severe combined immunodeficiency patients, there was a 25 to 40% rate of leukemia. Now, obviously, people have been working on gene therapy for about 30 years, and there's been lots of changes to the way that the vectors have been designed. And when I'm talking about gene addition, now we're going to talk about the applications. I'm going to talk about gene addition for thalassemia, gene addition for sickle cell, and gene modulation for sickle cell. So when we're talking about gene addition, I just want to tell you in a bit more detail what we're talking about in terms of the vector. So I can't point from here because of this monitor, but what you can hopefully see is that the vector, which is called LentiGlobin, that's one of the vectors that's been designed, it includes the beta-globin gene, but in fact it's not the native beta-globin gene. It's this gene called T87Q. And T87Q is almost identical to beta-globin, but it has an amino acid substitution that makes it an anti-sickling globin. Now, obviously, you're thinking this is going to be useful for sickle cell disease, where you're going to be introducing a hemoglobin that reduces the rate of sickling, but it's also useful for thalassemia because one of the advantages of this globin is that it shows up on an HPLC trace, which means that you know exactly how much of the patient's hemoglobin is due to the gene that you've introduced. You will also see that it's got its own enhancer, and the enhancer is supposed to be very strong so that irrespective of where the gene is integrated, it will be able to have lots of copy numbers. And then you can see these black lines on either side, and those are insulators. And that's to prevent the problem I showed you earlier where a gene is silenced. So these insulators should not allow the heterochromatin to spread onto where the gene integrates. So what about gene addition for beta thalassemia? So there's been several of these studies that have been reported. So those of you who went to ASH will have heard about this, and also it's been published in the New England Journal of Medicine. So this is gene therapy in patients with transfusion-dependent beta thalassemia. And it's the results of 2 phase 3 studies. It's the North Star 2 and the North Star 3 studies. The North Star 2 studies had 18 patients, and it was run in the US, in Australia, and in Thailand. And a North Star 3 study is 4 patients that were run in Paris. And the reason I've put this hypertransfusion is that these patients underwent at least 3 months of hypertransfusion before they had their stem cell collection, which was different from the patients in the North Star 2. So this is the patient characteristics, and what we want to focus on is the genotype. So there were, for the North Star 2 study, there were 8 patients with beta-0 or IVS1110 mutation, and then in the other one was 1 patient. There were 6 patients with hemoglobin E beta-0, and 3 patients for the second study, and then there were a few with other genotypes. And this is the bottom line of the results. So we've divided this between the ones who were beta-0, non-beta-0 or beta-0, and you can see of the 13 patients that were non-beta-0, 12 became transfusion independent, and of the 9 that were beta-0, only 3 became transfusion independent, but of the 6 that didn't become transfusion independent, there was a 73% reduction in transfusions. So if we go back to the clinical management we've been hearing about this morning, then obviously we would hope that our patients could become transfusion independent, but a 75% reduction in number of units would solve a lot of problems. It would go a long way towards that. So on this figure, you can see all the patients who who became transfusion independent. So the blue bars are from the North Star 2 study, and the red bars are from the North Star 3 study. And these above the line are the non-beta-0, and below the line are beta-0. And the pale color is when they were receiving transfusions, and the dark color is when they stopped receiving transfusions. And on the bottom axis, you can see the months since the drug was infused. So you can see they all became transfusion independent. What you have to be a little bit careful about is what do we mean by transfusion independent, because these 3 patients had hemoglobins of 82, 97, and 93, which is possibly not, and some at the bottom, 90 and 83, possibly not as high as we'd like it to be. Now, what's very clear about this is that there's a direct relationship between the number of vector copies in the cells at 6 months and how much hemoglobin of this T87Q they produce. So really, if we want to improve this, we have to find ways of targeting more cells and making sure each cell has as many copies of the vector as possible. What about sickle cell disease? So for sickle cell disease, there was a case report in New England Journal of Medicine, also in 2018, which I'm going to present to you. So this was a boy with hemoglobin SS who had numerous vaso-occlusive crises, 2 episodes of acute chest syndrome, and bilateral hip osteonecrosis. So he was about 13, and he'd also had cholecystectomy and splenectomy. He'd been given hydroxycarbamide from the ages of 2 to 9 without any improvement, and he'd started on an exchange transfusion program. And then at age 13, he entered into this clinical trial for gene therapy. So here we can see his hemoglobin. So the gray line is the total hemoglobin. The blue line is hemoglobin A. So that's obviously the transfused hemoglobin, which is going down because they've stopped the transfusions. And then you've got the green line and the black line. The green line is hemoglobin S, and the black line is the T87Q. So you can see that essentially it's as though he became a sickle cell carrier. And as well as seeing all these changes in his hemoglobin, the most important thing is he had no more sickle-related events, and all his pain medications had stopped by 15 months post the gene therapy. What about gene modulation for sickle cell disease? So we've got natural variations in hemoglobin F, and I think everybody will be aware of that. Hemoglobin F traits, it's a heritable trait, and it has an important effect on the sickle cell disease phenotype. And this is both on the onset of symptoms, but also in the severity. So with patients who have a naturally higher F, or whose hemoglobin F level goes up with hydroxycarbamide, we know that we can reduce the rates of acute painful episodes, leg ulcers, there's less osteonecrosis, less frequent acute chest syndromes, and reduced disease severity. But it doesn't affect the rates of priapism, renal dysfunction, or silent cerebral infarcts or stroke. So the holy grail with respect to hemoglobinopathies is to reverse the switch. So we know that gamma globin production stops, reduces around the time of birth, and beta production increases, or obviously if you've got sickle cell, that's not normal beta, that's sickle. And so people always talk about reversing the switch, and I find that that image sounds quite simplistic. So you assume that there's a single switch, you can switch it back, and then you'll start to produce your gamma. But actually, if you look at the regulation of beta globin, the switch is far, far more complicated. It's much more like trying to control an airplane. So in this cartoon, I'm going to try and illustrate a little bit of what we know about how we can control the switch. So this is the beta globin cluster on chromosome 11. We've got 5 enhancer sites, which make up the locus control region. We've got our gamma globin genes, and we've got our beta globin gene. And the way that we go from gamma to beta, actually, we don't need to turn on beta. What we do is we turn off gamma. So during embryonic life, gamma, being closest to the locus control region, gets expressed first, and you're producing your gamma globin gene. And then as you do the switch, you stop producing the gamma and you start to produce the beta. And the only way you can do that is by actually repressing this gamma. So when we were talking about heterochromatin earlier and all the epigenetic changes, this is what happens at the gamma. So that's how you do your switch. And if we look at what actually controls that repression, there's lots of different factors, but one of those important factors is called BCL11A. So BCL11A will come along, it will bind to gamma, and it will recruit lots of co-repressors so that we stop being able to produce gamma. And therefore, when we're trying to control the switch, if we can act on this repression, that's one way of essentially de-repressing the gamma gene. Okay, so if we could stop that BCL11A, then we'd be able to continue to produce your gamma globin gene even in adulthood. So how can we do that? So we've got to go one level up. We know that BCL11A is important in controlling that switch, so how can we control BCL11A? And there's 2 ways we could do that. One is we affect its enhancer. So BCL11A has its own enhancer. So if we could break this enhancer, we could stop producing BCL11A, and then that amount of protein would reduce. And then the other way is by giving a short hairpin RNA that would actually, you're not affecting the genes, you're just affecting the protein production. So if you've got a short hairpin RNA that binds to the BCL11A RNA, it goes to the RISC complex, which causes degradation, and you don't have any more BCL11A. So I just want to be very clear that when we're talking about sickle cell disease in this approach, it is still gene therapy in the sense that we are introducing a lentiviral vector, but there's no gene in that vector. It's a short hairpin RNA. So we're delivering an antisense RNA to BCL11A. So again, this data is really exciting, and it was presented at ASH. So they've now done 3 patients using, this is the Boston team. They do an autologous stem cell transplant, so they collect the cells by plerixaphore, mobilization, and apheresis. They transduce under GMP conditions with this lentiviral short hairpin RNA vector. They collect their cells, and then they infuse the transduced product. And they found that they had 3.3 to 5.1 copies per cell. And this is the results of one of the patients. So what we're looking for here, this is the baseline, and this is by day 76. So you can see the hemoglobin F levels and the hemoglobin S levels. So if you compare the proportion of hemoglobin F, you can see that that's increasing from 0.8% to 30% here. And you are increasing the proportion of F cells. But more importantly, you're not just increasing the hemoglobin, but you're also reducing hemolysis. So here you've got your LDH, which is starting off in the 500s, and then that goes down to 187. And I haven't got a picture of it, but there's a very nice blood film where you can see resolution of a lot of the sickle cell changes. So we know that the blood film is improved, and also the reason for taking this approach is that they thought it would have less off-target effects, because all the approaches I showed you earlier, you're integrating a gene into the genome, so there are worries about leukemogenesis, etc. Here we're not touching the genome, we're just giving this short hairpin RNA in the cytoplasm. So these early results show that it was possible to enroll, it was possible to modify all the cells, and it was the first proof of principle demonstrating this shRNA-based gene knockdown in humans. And also it showed successful rapid induction of hemoglobin F in the first patient infused. So they were hoping that based on this trajectory that you could fully suppress the sickle cell disease phenotype. Okay, and then this slide, I'm afraid, has gone out of order. This slide was meant to go with the gene addition. So I was talking about adding the T87Q in sickle cell disease. This is the update that we've had recently from Dr. Alexis Thompson. And what they found is they've done more and more patients, and they found that they were able to change, when they were doing the first patients, they were taking bone marrow to do the to collect the cells and do the gene modification, whereas now they're using plerixaphore and they are using peripheral blood monocytes. And they found that they're able to get more and more of the anti-sickling globin into the patients. So now I'm going to move over to genome editing, and I'm going to start with the technology and obstacles. So this is the same slide I've shown you before. So whereas before I was telling you that what you do ex vivo is you introduce a lentivirus with a new gene, here we're introducing the genome editing machinery instead of introducing a gene. So how does this work? Well, we're introducing the genome editing machinery to go and change something in the endogenous locus. So this should really get rid of the ideas of the gene being silenced, or should get rid of the leukemogenesis potential, because we're not touching the rest of the genome, we're only touching the gene in its endogenous locus. So how can we do that? Well, there's lots of different technologies. I'm going to focus on the CRISPR-Cas9 technology, which probably a lot of you are familiar with. But essentially, it's using some nucleases, which are combined with a DNA targeting part. So you're using something that can cut double-stranded DNA, but you're targeting it to specific areas of the genome. So they're engineered nucleases. So what happens if we get a double-stranded break? And we get double-stranded breaks all the time because we're exposed to lots of different agents that can threaten the integrity of our genome. And we have two different ways that we can respond to double-stranded breaks. One is called non-homologous end joining, and one is called homologous directed recombination here. So non-homologous end joining means that you just try and repair those missing nucleotides without using a template. And this can be successful, but quite often it leads to small deletions or insertions at the site where there's been the double strand break. Whereas if we do homologous directed repair, we are using a donor template, which endogenously will be the other allele that hasn't been broken, and we're copying the correct bases that are missing. Now, if you were thinking about how to do genome engineering, you would think we're going to use this technology because we're going to be able to fix the mutation in the body in the endogenous locus. But in fact, it's this technology, it's the non-homologous end joining that we're using rather than the fixing mechanism. And the reason for that is, first of all, it's not possible yet. So there's lots of animal studies that are ongoing and lots of publications about whether it's possible or not, but it's certainly not possible at a level that we could do clinical trials with. But the other thing to think about is that this would work very well for sickle cell disease, because everybody with sickle cell disease pretty much has the same mutation. So if we could go in and fix the sickle mutation, that would pretty much cure all the sickle cell patients. But obviously for thalassemia, that's very different. So there's so many different thalassemia mutations that it would be incredibly expensive if you had to tailor this technology to every individual patient, which is why we've got a one-size-fits-all solution, and the aim is to increase hemoglobin F rather than fix the beta globin. So if we're aiming to increase hemoglobin F, suddenly this braking mechanism starts to look better. Because if you remember what I told you about BCL11A, BCL11A is controlled by an erythroid-specific enhancer. So if we can break this erythroid-specific enhancer, we will stop making the BCL11A protein, and we'll be able to increase hemoglobin F levels and ameliorate both sickle cell disease and thalassemia major. So, final part of the presentation, where are we with all this? So, genome editing, this all works in vitro. This has been shown to work in mouse models, but now we're on to human studies. So when I say human studies, there's actually a lot of studies that need to go on before or at the same time as we're trying to do the experiment in real patients. So there's lots of studies, human studies, that have been looking at efficiency and off-target effects. So I told you that we're not changing anything except the endogenous locus, in this case the enhancer to BCL11A, but of course nothing is 100%, and so there will always be off-target effects. So there's lots of studies that are looking at off-target effects, and it looks like these are much, much reduced in genome editing compared to gene therapy. And then there's studies about the safety. There's studies about the bone marrow niche in sickle cell disease, because we know that sickle cell patients have a lot of inflammation, and the bone marrow niche is not very healthy because there's chronic hemolysis, chronic inflammation. And then there's studies going on about patient acceptability. But there is a trial in the UK that's currently recruiting thalassemia and sickle cell disease patients that is using genome editing to break the BCL11A enhancer. So I hope I've given you a bit of an overview about gene therapy and genome editing. I hope you've got it clear in your mind what the different approaches are, whether we're using gene addition or gene modulation. I think this is an extremely exciting field. There's lots of people working on lots of different approaches, and we don't know yet which one's going to be the safest. And I haven't talked at all about safety, and that is going to be, there's both the safety short term, but there's going to be the safety long term when people have had this and been followed up for years. We don't know what's going to happen yet. Thank you very much.
Thank you very much, Dr. Roy, for this very interesting talk and very promising for the patients. Floor is open for questions. We have some time. Yes, please. Mike, يا جماعة.
Thank you very much. It's really interesting, a very interesting presentation. I have two questions, please. First, you spoke about gene addition. For gene addition, how frequently you have to redo this addition? And are you sure it's not carcinogenic? For how long have you followed your patients? There was no any mutagenesis that happened through the introduction of these genes?
Yeah.
Okay.
So to answer the first question, it's a one-off. Okay, so it should be stably integrated, and the stem cells should have, so essentially you're modifying stem cells that should be stably transplanted into the patient's bone marrow. So we're not expecting that we would have to repeat the procedure, so just one would be fine. Now, what the long-term safety is, so for the gene addition ones, there's been, I mean, the follow-up has been, 2-3 years maximum, so we don't know long-term. I can tell you, this was presented at ASH and it was all over the news, that in the sickle cell study, out of the 4 patients that had the vector with the T87Q, gene, 1 patient got myelodysplastic syndrome. So that obviously raises a lot of questions and worries. But what they've done is they've looked at that clone, and that clone didn't contain the vector. And so therefore they're saying it's not related to the vector.
So they assumed it's a coincidence.
Yeah, exactly. So I think what's really important is, we're going to need to do these long-term studies, and I think it's very important that the patients understand the risks that they're exposed to, and for patients it becomes their decision whether they want to participate or not. But one of the key problems is that the busulfan conditioning is very toxic. So if we could do this with less severe conditioning, that would probably reduce the side effects. All the side effects at the moment are due to the busulfan conditioning.
My second question, please, are you familiar with the peptide nucleic acid nanoparticles gene editing instead of the CRISPR-Cas? Because according to there are only 2 studies, and their off-target results are, yes, were 0.0 something.
Yeah, I'm not that familiar with it. I think we're about to hear about nanoparticles, so hopefully we can
maybe the next
hear about that very soon.
Yes, maybe this will be covered at the next. Any other questions, please? There was one here, please.
Could you shed a light on the use of BCL11 and its impact on the lymphocyte?
Yeah, so that's a very good question. So BCL11A stands for B-cell lymphoma. That's what the BCL stands for. And I think there was a lot of reticence to believe that it had anything to do with erythropoiesis when it was first identified through some GWAS studies. But essentially it has its own erythroid-specific enhancer. So people who don't work on BCL11A say they want to stay away from it because they're worried about leukemiogenesis or lymphoma. But actually, people who do work on it feel it's very safe because we're only targeting an erythroid enhancer. And so when you look at the off-target effects on the BCL11A target, there are off-target effects, but none of them impact the non-erythroid BCL11.
There is a comment from the chairperson.
Thank you very much for this nice, simplified talk. It's marvelous. I think we need to put maybe a comparison between the allogenic hematopoietic stem cell transplantation and the autologous gene therapy modified cells that you do. I think it would be much safer than the allogenic. Maybe side effects will be much less, even with the busulfan toxicity, because we give them a myeloablative regimen.
I mean, the other thing is most of these studies have been done in adults. There's a few pediatric patients now that have been done, and certainly, I mean, in the UK we can't do allogeneic transplants for sickle in adults. So, and the thalassemias are all in as children. So I think once we get the data on safety in children, then doing a head-to-head comparison is probably going to answer the question, isn't it?
Thank you.
Any more questions? Okay, then thank you very much, Dr. Roy. And we move to the next.